what are the most common bile acids? Meaning, what are the names of the most common bile acids? Anybody? No, you guys are studying for micro. Totally get it. Totally get it. Chinodioxycholic acid and cholic acid, right? Sound familiar? Sure. So what happens to these when when a taurine or glycine is added to them? They become bile salts. And what is that process called when a taurine or glycine is added to them? Conjugation, right? Okay, good. Yeah, see how we do that. See? Right, next question. What is the mechanism of action and treatment for carbon monoxide poisoning? Let's start with one. What's the treatment? Hyperbaric chamber oxygen. Perfect. Yeah. Now, what's the mechanism of action? Absolutely. Perfect. Okay. Reversibly binds to the heme A3 copper center, preventing oxygen from binding in complex. All right. No, y'all looking at me like,
Oh, I agree.
you agree? Okay, good. Appreciate that. Appreciate that. All right. Now we're going to start with something new because you guys look like you're sick of the reviews. So today we're going to talk about biosafety levels and biological warfare agents. There are 4 biosafety levels, and there are 3 categories defined by the CDC, Center for Disease Control, for biological warfare agents, and we're going to talk about those today. Just some general study tips for the exam. Sorry, this slide should have been up front, but just remember the pathway overview summary slides. There's a lot of pathways in the first lecture, but similar from the last exam, just remember the rate-limiting enzymes, knowing the names of the intermediates or the substrates that are important in the pathways, and also knowing the enzymes that are involved in any deficiency. And there are a couple of conditions that we talked about where there's enzyme deficiency. So knowing that, and also for the case studies. So for the case studies with the ABGs, the arterial blood gases, just knowing how to complete the arterial blood gases is what I want you guys to know for that. Then we saw some case studies for the toxicological emergencies, and we're going to see some today. So for the toxicological emergencies, of course, the treatment, enzymes involved, and any major symptoms that are present in those conditions that we talked about. And then today, we're going to talk about some case studies of some infectious or toxic agents, and just knowing the major symptoms, the how to diagnose it, what the main diagnostic metric is, and what the main treatment is, and if there's any prophylaxis or vaccine. And there's a table at the end of this lecture to give you that information in a snapshot. So that should save some time when you're trying to organize yourself when studying for the exam. So biological warfare agents, what are they? They're anything that, be it an infectious agent or a biological toxin, that are used to harm people or kill people. And those have been used throughout history. Before the Common Era, it was used in what is now known as Turkey by the Hittite population. They used the Francisella tularensis, I don't know how to pronounce these words, but this was an agent, it's typically called rabbit fever. So what they did was they would, to throw dead carcasses of rabbits into their enemy's area, and basically their enemy would get sick and incapacitated and even die. So this gave the Hittite group an upper hand when in combat. And so this was several thousands of years ago, and they have been used throughout history. World War II, we saw some countries using the plague. We're going to talk about the plague in more detail today, and also not so much in combat settings, but we've seen that anthrax has been used in 1995 in Japan as a subway. You guys may not have been born, a lot of you. Sorry for that old reference. But then 2001, it was used, carried by our mail postal system in the District of Columbia. Anthrax was, and so some people got sick, and I believe one or two people might have passed away from that anthrax exposure. We're going to talk about anthrax as well. And so in 1975, the Biological Weapons Convention or Warfare Convention stopped the use of biological warfare agents in combat, although we still believe some countries, even though there are a number of countries that signed that they would also stop making them and stockpiling them, we don't believe that all the countries have done this, and we believe that several countries out there are still making them. And so that makes it very scary for us in terms of our next combat, because it's something that can be used, and it's something that's very easy to use in warfare. So since you guys are going to be clinicians and you're going to be in combat settings, like the first line, probably the first line here, knowing a little bit about it and knowing how to treat it is very important. And also, and that's when you're fighting fighting in combat settings away from this country, but there's also outbreaks in the country and here in the United States, so you guys will need to understand how to treat your patients and how to contain them. So we're going to talk about a little bit about that today. In that, we're going to talk about how biological warfare agents are contained, and they're contained by biosafety levels, BSL levels. So how many of you have worked in a lab? There's a couple. Are you lab tech? Lab tech, no? Okay. So if you worked in a lab, any lab that you work in has a BSL level. So the levels go from one through 4, with 1 being the agents in that setting are least likely to cause harm in a healthy person, all the way up to level 4, and that's in that pyramid at the bottom. Each subsequent level is nested, so level 1 is nested within level 2, and level 2 and 3, and so forth. And so biological safety levels 4s those are very dangerous and toxic agents. And do you guys know the name of the BSL 4 lab in the United States? Say it again. Anybody? USAMRI? Somebody say USAMRI? USAMRI. We have a BSL 4 in the military. I don't know if you guys, for real, you guys might be too young for this, but there was a movie called Outbreak, and it was based on scientists at USAMRI, and the outbreak was kind of similar to a biological warfare attack. So each of these 4 levels has specific containment requirements and also has specific protection that a person must take in order to maintain the safety of our environment and those that are in the laboratories. So for BSL 1 microbes or agents, these agents are thought to not be harmful for healthy patients. An example of a BSL 1 agent is E. coli, and this non-pathogenic E. coli is found in our digestive tract, so it's something that is deemed to be safe. Now BSL 2, remember BSL 2 has BSL-1 nested into it. And these agents or microbes pose a moderate hazard to the environment and to the laboratory personnel working with the agent. And an example of this is Staphylococcus aureus. So this is typically harmless. However, when we come across a strain that is antibiotic resistant, this could be very, very dangerous, and it can cause significant issues with a person exposed to it when there is antibiotic resistance. BSL-3, the route of exposure primarily for BSL-3 agents is inhalation, and that is very dangerous. The products are the microbes aerosolized and are in the air, they're breathed in by a patient, and these can be very harmful to the person's exposed. These agents can be found locally where it's being studied or where it's being tested, or it can be exotic, meaning that it's from another country and it's brought into our country by a carrier or biological warfare position. An example of this is mycobacterium tuberculosis, and of course we've heard that example. We have to get screened for that when we join the military. What I found was interesting, I wasn't aware of this, is that this tuberculosis can get everywhere in the body essentially. So it can even get in our bones, and when it does, it can cause severe deformity. That's a condition called POTS syndrome, or POTS disease. And so I wasn't aware that it could circulate in our bones. That was kind of scary to think about that. And then, of course, BSL-4, we talked about that the eusaridin being it's not only, it's DOD's premier BSL-4 laboratory. Of course, when we think about these agents, we think about Ebola. That was an issue in the early 2000s that the military responded to. And there was even several officers, several groups that deployed to try to contain and treat people in Africa that were suffering from Ebola. And so these are also inhaled or aerosolized agents that, that's how they are transmitted. And unfortunately, there's no vaccine or no mainstay treatments for a lot of them. So you can only treat with supportive care primarily, and basically, since there's no vaccine, most of the people that suffer from this will pass away. Any questions about the BSL levels? All right. So, how does the Center for Disease Control categorize or group these agents? And they're grouped categories A, B, and C. So most of a BSL-3 and 4 lab are responsible for housing or studying or containing the biological warfare agents in all of the categories. So that's how these two systems work together. So if you have any category A, B, or C, it's going to be housed or stored or maintained in a BSL-3 or BSL-4 laboratory. So, as I mentioned earlier, because we're at risk of potential biological warfare and different warfare in general, you guys are going to be on the forefront treating this and knowing how to treat it. And military in general, in addition to the public health services, will likely respond if there's any issues or local issues with biological warfare agents in the United States. So it's important that the government places important priorities on these. So understanding how to treat them is of utmost importance. So when we talk about the different categories, category A poses the highest risk. It results in a lot of sickness and a lot of death. This is easy, these agents are easy to transmit and disseminate, and so some examples are shown here. I already mentioned the tularemia that was used for the common era, but we're going to talk about 3 different examples: anthrax, botulism, and plague, and those are the only ones that you guys are going to be testing. So, for anthrax, this case study, a 45-year-old postal worker presents to the emergency department with a 2-day history of fever, fatigue, dry cough, and mild chest discomfort. He mentions handling an unusual powdery envelope earlier in the week. Over the next 12 hours, his condition rapidly deteriorates, developing shortness of breath, profuse sweating, stridor, which is like a high-pitched, harsh crowing when breathing, cyanosis, that's when the person looks blue, their lips look blue because their oxygen saturation is low. And this person ended up becoming hypotensive and entering shock. So how is this diagnosed? So this is diagnosed, the mainstay diagnostic assay for this is a chest x-ray, and you will see a widened mediastinum and pleural effusions. So that means basically the cavity that stores the heart, lungs, and major vasculature is widened. And that's because these inhalants, this anthrax spores will enter the lungs, and it's going to cause inflammation, and it's going to expand that whole area. And that's why you'll see fluid or effusions in the lungs. There's also some other means to diagnose this, of blood culture, of brain staining, and a PCR antigen detection. You would treat anthrax poisoning with high-dose IV antibiotics. Those are the antibiotics that are preferred, but for testing purposes, antibiotics is what we recommend. And there is a vaccine for this, and it's a time course, several doses up to 18 months, and then annual boosters. For botulism. So during a local outdoor festival, multiple attendees arrived at the emergency department within 24 to 48 hours, reporting a constellation of neurological symptoms. A 40-year-old woman complains of blurred vision, double vision, drooping eyelids, and dry mouth. She reports progressive difficulty swallowing, dysphagia, and a weak, breathy voice, dysphonia. On exam, she shows cranial nerve palsies and begins to experience symmetrical descending flaccid paralysis. Within a few hours, several other report to the ED with similar findings. One progresses to respiratory failure, requiring intubation. So the diagnosis for this is done by the mouse bioassays, the gold standard for this. And what happens is, so a serum sample taken from a suspected patient would be injected into a mouse, and then you would wait for the mouse to exhibit paralysis and symptoms associated with paralysis. Now there's only one drawback to this assay. It typically takes up to 4 days. So you might want to use some other means of testing a person, including nerve conductivity studies. Of course, the nerves will be affected, and that's going to affect their motor function because of botulism impacts that. So you would treat with the pentavalent antitoxin, and also you may need to use supportive care, intubation, and mechanical ventilation for those that have experience of respiratory failure. And there is a prophylaxis. There is a pentavalent antitoxin that's available. However, it's not FDA approved. It's what's called a IND. It's an investigational new drug, and it's used in high-risk personnel in laboratory or military personnel that might be exposed to Any questions? Another Cat A agent of concern that has been used throughout history as a biological warfare agent is the plague. So in this example, a 28-year-old previously healthy male presents to the ED with a sudden onset of high fevers, chills, headache, and productive cough with blood-streaked sputum after a 3-day flu-like illness. Over the next 12 hours, he develops progressive dyspnea, cyanosis stridor, and becomes hypotensive. And there are several other patients in that area that have developed similar symptoms. So, in addition to the signs and symptoms mentioned in the scenario, malaise, of course, the person is fatigued, and hemoptysis, which is that coughing up blood that was determined by the bloodstream sputum. And then also, a person may have swollen lymph nodes, which is the bubbles, which is bubonic plague. That's how bubonic plague got its name. And then in severe cases, a person may experience respiratory failure. So the main treatment for this is blood culture. And then you can use ELISA or some other immunoassay as a secondary diagnostic means. Treatment, antibiotics immediately, and the first line being streptomycin, gentamicin. And if the person has meningitis, then you might want to add chlorphenicol. And there is prophylaxis, and that's 7-day dose of doxycycline for persons that may be exposed to in an environment or to someone that has the plague. Of importance is how this plague is passed, and the genus and species is Yersinia pestis. Have you guys learned about this in micro? Or you guys started? So you already good. We may see that one again. Just saying, maybe. Okay. Any questions about that? Now we're moving to category B. Category B is the second highest priority. It's moderately easy to spread, and it causes low death rates, but still a significant amount of personnel being sick. And we're going to talk about 2 examples. Ricin, which comes from castor beans, and then staphylococcal enterotoxin B. So in this scenario, a 34-year-old warehouse worker presents to the ED with fever, chest tightness, cough, shortness of breath, nausea, joint pain, and that begins approximately 6 hours after working near a damaged shipment of unknown powder. Over the next 12 hours, this patient develops worsening respiratory distress and pulmonary edema. And unfortunately, he has to be transferred to the ICU, and then several other workers report to the ED with similar symptoms. The main symptoms are chest tightness, shortness of breath, which progresses to respiratory distress and in some cases pulmonary edema. This would be diagnosed by an ELISA assay, looking for antigens of this toxin. And unfortunately, the best treatment is supportive care. So you would want to manage their pulmonary edema, and you may need to use mechanical ventilation if that person experiences, that patient experiences respiratory failure. And there's no approved vaccines, so the recommendation is mask is the best protection. And there are 2 investigational vaccines. Rivax is in, I believe, phase 2 of clinical trials, so it's shown evidence in the animal trials, and we're going to talk about the clinical trials and research evaluation as we teach you guys that as well. Ivex is still in the animal models, and so that still has a much further way to go in order for us to know if it's a viable candidate for a vaccine. So right now, no approved vaccines for ricin, which is a category B agent. Now for staphylococcal enterotoxin B, a 40-year-old male presents to the emergency department with a sudden onset of fever, chills, headache, muscle aches, and a dry cough for roughly 8 hours after cleaning out an abandoned facility. He reports mild chest discomfort and shortness of breath, but vitals are stable. His chest x-ray is unremarkable, and again, several other co-workers are experiencing the same. So diagnosing this condition is that febrile respiratory illness, which means that a person will have a normal or no radiological findings, but they'll present as if they have pneumonia, so they'll have a cough, they might have sore throat, things like that. The treatment, unfortunately, no major treatments, and supportive care as well for this condition, and fluid management and mechanical ventilation if the person progresses to respiratory failure. There is no vaccine for this, and again, masks are the best prevention. So, category C, these are placed kind of at a higher priority than their category because they're easy to engineer and to mass produce and disseminate. And we're going to talk about one example, hantavirus today, and these unfortunately can cause high sickness and high death rates as well. So, hantavirus category C, a 32-year-old male construction worker from rural New Mexico presents to the emergency department in early summer with a 3-day history of fever, muscle aches, headache, chills, and dizziness. He also reports GI issues and a non-productive cough along with episodes of lightheadedness. He denies any recent travel, but mentions cleaning an old rodent-infested shed the previous week. On physical exam, the patient is febrile, tachypnic, and has tachycardia. Lung auscultation is clear, there's nothing in the lungs. No rash or significant findings from the chest exam. O2 saturation is borderline low. Chest images may later reveal fluid in the lungs or signs of pulmonary edema. So diagnosing this patient will be through ELISA assay or real-time PCR. What you notice about the symptoms is, again, that it's what's called febrile prodrome, fever followed by other symptoms that are associated with like issues with the lungs. In this case, it could progress to pulmonary edema. And the treatment is non-specific. There's no specific treatment for this as well. And there's no cure or prophylaxis, no vaccine or prophylaxis. And here is a summary of everything that we went over today. Are there any questions? Yes.
So it looks like category A and C are both high priority agents and result in high morbidity and mortality rates.
Mm-hmm.
So I guess what's the difference between category A and C?
I think the category C is more easily disseminated and more easily, like you can engineer that in the laboratory faster and then get it out and spread it to people faster than some of the agents in category A. Because typically they like to keep category A agents because they're so dangerous, they're kind of on lockdown. Like they, you know, of course you can be exposed to them in the environment, but typically, like if those get out, those would cause a greater risk to like the environment and to the laboratory than with category C, for example, if that makes sense. Any other questions? All right, I'll see you guys on Monday.